to be alive.
Good evening. Welcome to iFocus International Masterclass Series. This is on cornea. There are 10 lectures in this series. We have done 5 already, and today is the 6th lecture by Professor Jodhbir Mehta from Singapore National Eye Center. And he's going to talk to us on surgery for pediatric endothelial tumors. Before we begin, I would request Rolika Bansal to introduce Professor Mehta, and then he will deliver his talk. Rolika, can you share your screen and introduce Professor Mehta, please?
Yes, sir. My screen is visible, sir.
Mm-hmm.
Okay. So here we welcome Professor Jodhbir Mehta. He graduated from Guy's and St. Thomas's Medical School, University of London, UK in 1995. He did his basic and advanced specialist training at Moorfields Eye Hospital, UK, and also did subspecialized fellowship training in cornea external disease and refractive surgery at Moorfields Eye Hospital and Singapore National Eye Center. He's currently the head and senior consultant, Cornea and External Eye Disease Department, Singapore National Eye Center, Director of Research at Transplant Center, and Program Director, Corneal Transplant Program, among many of his professional and academic appointments. Professor Mehta's clinical work is mainly in cornea transplantation, both basic and advanced forms, anterior segment reconstruction, and in refractive surgery. His clinical-based research involves research into imaging devices for the cornea, case comparative cohorts of new selective tissue transplantation procedures compared to penetrating keratoplasty, examining complications and outcomes of these new procedures. He's also involved in collaborative research studies in randomized controlled clinical trials in dry eye and a large multi-center infectious keratitis study and a large spectrum of basic research. Professor Jodhbir Mehta is also committed to clinical teaching other surgeons, both in Singapore and internationally in USA, Europe, and Asia on advanced forms of corneal transplantation and corneal imaging, and has been invited worldwide to give lectures on these surgical techniques. Professor Mehta has won 42 awards in the UK and internationally for clinical and research work. Most recently, the Nakajima Award for 2013 Asia Pacific Academy of Ophthalmology, American Academy of Ophthalmology Senior Achievement Award 2017, and Costa Lecture from the Australian Corneal Society 2018. It is a distinct pleasure and a privilege to have Professor Mehta as a part of iFocus Online International Cornea Masterclass Series and deliver a keynote lecture today. We welcome you, sir.
Thank you, Rolika. Thank you for the kind invitation and the kind introduction for my talk. So I'll be talking about pediatric endothelial disease and how to basically manage this condition surgically. Okay, so the slides are okay?
Yes, Joe.
Yeah, okay, great, okay. So again, thanks very much for the invitation. So we'll get on and I'll talk about the surgical management of pediatric endothelial disease. These are my financial disclosures. Some of the devices you will see we have patented and licensed to some of these companies that are commercially available. So when we think about the treatment for endothelial disease, we can see that over the last 20 years, it's changed significantly, really in the adult form of the disease itself. We've gone from full thickness transplantation or penetrating keratoplasty now to more selective forms of transplantation in the form of basically DSEC, and basically now into basically DMEC, where it's simply replacing disease decimated membrane with another decimated membrane endothelium. And also regenerative therapy now is starting to play more and more of an approach into adult diseases. And I'll talk a little bit about this on how we use this in pediatric diseases as well. We all know the risks of penetrating keratoplasty when performing this procedure. Essentially, it's an open sky procedure. And a lot of these risks, intraoperative and postoperative, are mitigated when we do lamellar keratoplasty because it's a relatively closed system. And when explaining this, it's almost like thinking about doing an extracapsular extraction surgery compared to basically a phaco emulsification. And it's really the reduction in complication and the improvement of outcomes that have really pushed us into performing the surgery more often. If you look at the rates of or keratoplasty trends in Singapore, for example, and if you look at the above 5 over here, this is adults, and then bottom over here is basically children. What you'll see is that endothelial keratoplasty became the dominant graft procedure in 2009, and steadily continued at that level around about 58 to 60% over the years itself. Anterior lamellar keratoplasty became the dominant procedure back in 2010 over penetrating keratoplasty, and penetrating keratoplasty now in adults is really considered the third choice surgical procedure. However, if you look at the figure below, this is over the same time frame from 2009 to 2019, you will see, even though we perform the same surgery, you will see that actually penetrating keratoplasty is still the most dominant figure in children. Anterior lamellar keratoplasty is second, and endothelial keratoplasty is down here basically in third. So there's obviously got to be some reasons why we don't perform this, or even if we try to perform this surgery, it's not possible to do this surgery in children, or the difficulties that are faced basically in performing this surgery in pediatric population. And this is really what I want to focus on during this talk, and some tips or ways on how you can basically do this surgery in children, but it does require a lot of modification of your surgical procedure. So the reason why these procedures are difficult is because obviously in children you have an immature ocular anatomy. So you have reduced scleral rigidity. The cornea is also basically reduced rigidity compared to adult. You have suboptimal compliance with medications. So it's very difficult sometimes in very young children to get medication inside the eyes. So of course you have a higher risk of basically getting rejection. And sometimes you don't even know if the child is actually undergoing rejection itself. And it's often difficult to perform pre-operative and post-operative diagnostic tests. And you have to always remember that unless the child is probably even in the early teens, even in the sort of late sort of 5 to 10-year-olds itself, but even in the early age, you have to think about doing repeat examinations under general anesthesia quite repetitively, almost every 6 to 8 weeks, until the eyes are really, really stable. So this requires a lot of effort by a multidisciplinary team to basically try to get the child's visual rehabilitation. If you look at the leading indications for pediatric endothelial surgery, CHED is the most common, PPCD or PPMD, Peters anomaly, then it can be corneal decompensation secondary to complicated cataract surgery, aphakic corneal decompensation, pupil-thalamus, desmoid membrane breaks, then we have traumatic aniridia and aphakia, and irreversible PK graft failures from having had a previous penetrating keratoplasty. So you can see the gamete or the diagnostic indications are very different to what we basically see in adults, and often a lot of the times the child will present with quite advanced stromal disease, and that's why we still basically consider doing penetrating keratoplasty as first choice instead of one of the endothelial basically procedures themselves. So if we look at some of the issues basically when performing the surgeries themselves, we can divide this into preoperative, intraoperative, and postoperative. So preoperative, of course, the assessment of the eye, and if we compare this from adults to basically children, the actual assessment itself can actually be quite difficult. Often the children will need sedation if they're very young to basically have a good look at the eye, or you may be able to have to do an EUA and OT, and then hopefully have some diagnostic instruments such as a UBM or an OCT in order to help you with your diagnosis. Obviously, when you're thinking about consent, you're not just dealing with the child, you're dealing with the parents and guardians, and it's really important that they have a good understanding of the outcome. The corneal transplant is not going to last the life of the child. It's more than likely the child will have to have recurrent surgery, requires a lot of follow-up, and it requires a lot of medication from the patients and from the parents to be involved in the surgery. So it's really a team effort to really get the visual rehabilitation in these children. When you go to intraoperative things, of course, all the surgeries under general anesthesia, scleral rigidity is less than the child, the operative field can be smaller. Sometimes these eyes can be quite micro-ophthalmic, so you're dealing with very small, basically, eyes, or small, basically, corneas as well. You must have much more higher posterior vitreous pressure than you basically do in adults. And obviously, even basically peeling the desmoid membrane alone can be very, very difficult in children because it's much, much more adherent to the posterior stroma. So if you're going to think about doing a DMEC or a DSEC procedure, just removing the disease from the desmoid membrane may itself actually be quite a challenge itself in a smooth plane without actually causing scarring. You have to also remember that often the AC is basically shallow. There may be other diseases of the iris segment. And of course, a lot of these kids, if they are basically phakic, is then going to basically shallow the anterior chamber. And often when we're doing adults, most of the time we make them pseudophakic because most of the surgery is done in adults over the age of 50 years old. Some of the surgeries we do, if they're less than 50, we do leave them phakic when we're doing the surgery, but the vast majority of the adults are pseudophakic. So this itself will deepen the whole anterior chamber. And then if we're considering an EK procedure, most of the time when we do EK procedures in adults, especially if we're doing DMEC, we always use gas, SF6, which obviously we cannot use in basically children. And for D-second, I'll basically use air, which is the thing that I normally will use basically in children. But I will also suture some of the grafts to Descemet's membrane. I've started doing this a lot more because of issues basically in trying to get the child to lie flat basically after surgery. So posturing itself can be difficult if you're looking at basically doing this surgery in children. Post-operatively also can be difficult. Maintaining position, of course, we always tell our adults to lie flat basically after their EK surgery, which can be difficult in a lot of children to get that air bubble to stick the graft in position. Then you can have issues with compliance of medication. This increases your risk of basically getting post-operative dislocation, especially if the child is rubbing the eye. And of course, remember, post-operative inflammation is going to be more in children compared to adults. Normally, I will give a course of oral steroids basically after some syrup after basically the surgery itself. So I'm going to just show some cases to illustrate some of the issues that you can basically have when doing this surgery in children. So this is a 10-month-old boy who initially presented preterm at 35 weeks. His bilateral anterior segment dysgenesis with nystagmus, microcornea, 8 millimeters at birth in both eyes. He had a developmentally glaucoma also in the right eye and also learning disabilities. And he underwent a penetrating keratoplasty in 2010. So this is almost 10 years ago, now 11 years ago. The best corrected visual acuity that was recorded in the notes was basically 624. He had a lens aspiration and a posterior chamber lens put in 2011. And you can see from the first graft lasted, a penetrating graft lasted 3 years. So in 2013, he had episodes of graft rejection. He's actually reasonably easy to examine, I have to say, compared to other children that I've seen. But, you know, he is not, because of his learning difficulties, he's not very verbal with saying he's having issues with his eye. So after that, he's been put on long-term pred forte with hypertonic sedative, and his cornea slowly decompensated. And this is a picture of his cornea in the top over here on the right side. This is the decompensated graft. His visual acuity now dropped down to count fingers when I basically saw him. His visual acuity in his left eye was basically 630. You can see the microcornea and the anterior segment basically dysgenesis. So this is a bit more high power magnified view. His operation got delayed a little bit. This was just before the whole COVID thing, and so it was pushed back a little bit for surgery. We used to get a little bit of flu, and then we had to cancel the surgery because the anesthetist wanted to basically give him a GA. And you can see here the edema got worse, and you can see how difficult basically the view is in this situation. So you're left with basically two options in this situation. He's a 10-year-old boy now. Do we do a repeat penetrating keratoplasty? There's a lot of stromal involvement over here, or do we try to attempt to do basically an EK in this basically situation? And these are basically the two options that we're left with. So after long discussion with the parents, I decided that what we're going to do is we're going to do basically an EK for him, and this is how we basically do the surgery. Okay, this is a surgical procedure. So we start with, so you can see the graft is actually quite small. I think it's a 7 millimeter graft. So try to improve the view. I did epithelial debridement basically on the surface. And because I'm going to use an endoglide, I'm basically going to do a scleral tunnel close basically to the limbus, because this is a very small eye. This will go through a 4.5 millimeter incision. So you can see how small his eye is, because that incision is actually only 4.5 millimeters. So use an AC maintainer. So the idea is obviously trying to deepen the AC as much as possible to try to release any PAS. I've done an inferior PI, surgical PI now to help to basically put the graft into position. All the wounds need to be sutured because, of course, the children leak like crazy, so you cannot afford to leave anything basically open. I'll just show you, I'm just practicing here with the forceps because I'm going to pull the graft in with the forceps, and I wanted to get an idea of the clarity of the forceps in the anterior chamber. So I always do this in cases like this where the views are very, very bad. So I have some understanding of how well I can see the graft basically, of how well I can see the graft basically inside the eye. Okay. So after we basically sutured venting incisions like we do on standard basically EK surgery, then we go prepare the graft. So the graft's prepared in normal manner. So there's going to be a small graft, probably going to be a 6.75 millimeter graft. So it's going to be inside the previous basically PK. In order to improve visualization in these cases with severe bullous keratopathy, I'll always stain the graft with membrane blue to help me when I'm trying to basically put it inside the eye. So the graft is basically loaded in the endoglide as usual. After basically the staining, normally we use the membrane blue for about 1 minute. Then I'll use basically some viscoelastic on the surface to protect basically the endothelial graft as I'm going to basically pass this inside the eye. It's a bit of viscoelastic protection. And this is loaded up into the endoglide. And so this is a small graft, so obviously the scroll will be very of the graft-host junction. So you have to be careful when you're doing EKs under previous PK, especially in these very, very small eyes, because the PK graft is right over here forming the new limbus itself. So what you have to do is you have to make sure you don't hit that inside graft-host junction edge itself. Okay, we're just basically opening it up. So you put the endoglide, you can see how big the endoglide is and how small this eye is itself. Okay, so you pull the graft in, so I can just about see the view from the vision blue. So I'm grabbing the graft, so you can just see the blue graft basically coming in now. Okay, so you pull the graft in, so you've got good control of the graft inside the eye. I mean, I know the view is pretty poor, but at least I know how the graft is basically going to open up inside the eye. It's going to open up with the endothelium on the inside. So you can imagine if you basically use a different technique where you have to flip the graft, or you basically folding the graft inside the eye, it's very difficult when the view is so poor. So the graft is flipped open. So on one edge is open. I put an air bubble on that side. You can see that this side is all open over. Oops, sorry. See, this side is all open on this side here. Okay, so that side's all open. So the air bubble goes on the one side. Okay, and then we start to suture up the wounds now. So it's very important to keep an absolute airtight wound itself. So once the graft's in position, I then start with the suturing. So I'll do this for most children, especially children who have learning difficulties, because it's very difficult to expect the parents to get these kids to posture. In order to basically suture this, normally I'll go outside the anterior chamber. You need long sutures that pass from the anterior chamber through the graft, through the anterior chamber, and then basically through the graft. And normally I'll put 4 sutures into the graft to keep this into position. And normally the 4 are normally quite good. I like basically putting in long sutures, because if you put long sutures, it's much easier to control the tension inside the eye. Okay. If you put short sutures in there, you're going to wrinkle the graft. Okay. You're going to basically wrinkle the graft there. Okay. So you need long sutures over here. It's much easier to control the tension. And again, then you can go back and then put a full airflow inside over here. And you can see I've sutured up the pull-through incision, sutured up the PI incision over here, and then I've sutured up the main incision. So in children, I suture everything as well. Okay, in adults, you can get away with keeping these basically open. You don't really need to suture them as well. The advantage of basically putting long incisions is much easier to control the tension, so you don't get wrinkles in basically the DSET graft itself. Otherwise, what will happen is you'll get wrinkles, and what you'll see is that it's attached in certain areas, but it's not basically attached in other areas where there's no basically sutures around that area. Normally 4 is normally sufficient to do this, but I found this the best way of suturing from inside. Another alternative technique that you can think about is putting a mattress suture through with proline. I've tried that. The only thing about that is you have to be very close to the graft as you're passing the proline suture across the DSET graft itself. So you have to be very, very close to the graft on the inside. It is easier to do that because tenoproline is easier to basically to handle than suturing on the side, but I actually prefer this technique. And once you can basically get the traction with the graft and understand how to basically do it. So this is what the eye basically look like. So this is day 4 post-operatively. You can still see there's an air bubble inside the eye. You can see how bad the view is. You can hardly even see the graft inside the eye itself. So we did no CT over here. You can see the central corneal thickness is about 794. So the stromal thickness 794. This is your DSET graft underneath there, the contact lens basically on the surface. So it's good enough to examine basically with a on a slit lamp. You can see over here. So you can see here that it nicely clears up, and I see this a lot in children. If you can do an EK, the stroma does dramatically clear. While sometimes in adults it takes a long time, but in children it seems to occur basically much faster. And you can see in the space of 2 weeks, the stromal thickness has gone from 700 down basically to 545, and visibly you can see the clarity of the graft itself. The sutures are basically still in place. This is basically at 2 months. Now the stroma is really cleared up. The stroma thickness is now down to 483. I've already basically removed the stitches, and actually I managed to do the stitches on the slit lamp for him, so I didn't have to take him back to OT basically to do that. And this is where we are now. So this is basically almost 2 years basically post-op. He's 624 in this eye. You can see that the stroma is really nicely basically cleared up. And he's got a much better, nicer view of the anterior chamber. You can see the PI, you can see all the iris features, and also basically his posterior chamber lens. His medication now, when he went past 1 year, so normally they'll be on 4 times a day on basically on a reducing dose. I do keep the steroids a little bit higher in adults and children that have had a previous penetrating keratoplasty. And of course, he's on glaucoma medication as well. So he's managed by one of the glaucoma team for that, to make sure that's basically under control, and just on lubricants initially. And his refraction is not so bad after that time period. And we've got him back to the best visual acuity that he's had since we had it recorded in the notes. But the key thing is that obviously having done a EK now underneath that graft, we expect this graft to last longer than its original penetrating keratoplasty. And if this ever fails, well, not ever, but I'm sure it will fail in the future. When it fails in the future, then I can replace it hopefully earlier. Maybe you would consider doing a DMEC for him underneath there instead of basically a DSEC. So let's show you another case. This is a 7-year-old boy now. It's referred to the corneal surface. But he was initially seen in another hospital. He's being treated for anastomotropic amblyopia in the left eye, and he's advised to basically do patching 5 hours a day. His best corrected visual acuity in the right eye was basically 6.6. Left eye was actually only 6.30 with this refractive error. And if you look very closely over here on the sclerotic scatter, you can see these little things on the endothelium on this side. It's slightly difficult to see based on the slit film, but it's nicely seen over here on basically the desmoid membrane. And this is it's an unusual form or a variant form of basically PPCD. Okay, you can see it's basically affecting his endothelium. His corneal thickness now is going up to 634, and the other eye, his corneal thickness was 502. So we had a long chat with the parents. As you can see, he's got a lens there, so he's basically faking, and we decided to do a DMEC for him basically in this side. So this is the surgery. So I removed the epithelium as well to basically improve the visibility. This is the AC maintainer is going to go in this situation. So you need to basically I like to use an AC maintainer in this situation to basically try to deepen the AC, because you want to try to avoid any lens touch basically during the surgery itself. So we're doing the PI basically through here first of all. So that's the surgical PI. And then basically once we've done the PIs, we're going to put a large airfill basically after finish surgery. This is an AC maintainer, and what you can see on the AC maintainer, this is different to a standard AC maintainer. The AC maintainer is actually sealed at the end over here, and the fluid actually comes from the edges on the side there. So there are 2 ports either way. So it's what we call a dual port AC maintainer. The advantage of this is that you can shallow or deepen the AC, and especially if you're doing DMEC and with a pull-through technique, it doesn't cause the DMEC graft to move inside the eye itself because there's no jet or basically fluid. So it's a very controlled way of basically deepening the eye, the anterior chamber. Okay. So typically I normally strip the desmoid membrane with basically air. That's what I basically do in the adults. So that's what I basically try to do. That's what I try to do here as well. But you can see that when we're trying to basically do that under air, you see how difficult it basically is, because what you have to bear in mind is that you don't have the rigidity that you have like you basically have in an adult cornea. Okay. So you don't have the rigidity like you have basically in an adult cornea. So as I'm basically going to try to strip the desmoid membrane, I'm actually finding it very, very difficult because I'm getting no basically counter traction or tension to strip the desmoid membrane away. The other thing you have to bear in mind is that in kids, the stroma is so much more stickier compared to basically in adults itself. So actually removing the desmoid membrane in children is actually very, very difficult. But we had to basically do this. You can see that's the level of basically the scarring was. The third issue is that, of course, when you're removing the desmoid membrane, you're actually trying to do it as smooth as possible, because if you get too many tags there, you're not only going to make it more difficult if you're doing basically a DSEC, but if you've already committed yourself to doing a DMEC in this situation, then you have to make sure that you will basically remove the tags. Otherwise, your DMEC graft is basically not going to basically stick, because you're going to get a dislocation in that area where the surface is rough. So these are all the difficulties basically faced when you're trying to basically do these cases. And in fact, it was very difficult to actually get a single plane of any tissue basically here at all. I actually just took this off in little shreds basically around from the desmoid membrane, because I couldn't actually get one basically sheet off itself. So I'm doing this on the Henon, which is something very different that I ever do basically in adults. And then I'm going back now and trying to remove any of the tags there, because what I'm worried about is that whether when I do a DMEC over here, whether the graft is basically going to stick because of all the tags. And I'm being quite careful now to try to remove as many of the tags that I can see physically possible, using the basic the 23 gauge forceps from the basically the stroma itself. Now we're removing all the Henon from the AC, because of course you've got to remove all the Henon, otherwise you can't basically put the graft in. Now, typically for the DMECs, I use an endoglide. So basically what we will do is we use a pull-through technique. So these are 27 gauge forceps that I'm going to pull basically the DMEC graft inside the eye. And we've already constricted the pupil down to try to basically protect the lens when we pull the graft in. So I'm just testing the incisions now. And one of the things in the pediatric cases is very important to make sure your incision sizes are only as big as they have to be. The nice thing about the 27 gauge forceps are they go through very basically tiny incisions. So I'm just testing basically incisions so I can feel what it basically likes. This is basically my DMEC graft. So our eye bank for the last 3 years now do basically pre-stripped tissue. I'm staining the graft with membrane blue, as you basically normally do. We're refining. This is all basically just standard preparation for DMEC. And I'll still use a marker. I don't use an S stamp when I do the surgery. I normally just use an asymmetric marker, which is cheap. You just use a pair of scissors with banners to cut an asymmetric mark on the edge of the graft, and that allows you to basically help you with the orientation. Membrane blue is quite useful, especially if you're doing cases where there's a lot of basically edema. And then I basically use the forceps to fold, a trifold technique over here. This is the standard, what we call endothelium in technique when we're basically doing the surgery. So the endothelium is on the inside. So when this graft is basically pulled in the correct orientation, it will naturally open up with the endothelium on the downside itself. So this is loaded up into the DMEC cartridge. So we basically just pull the Decimase membrane basically through into the cartridge itself. So it's just grab, it's pulled through the fluid BSS into the cartridge, and this will protect the graft when it's basically pulled inside the eye. Okay, so we put this inside the eye. And it's quite nice having that flange there because it basically protects the DMEC from the lens below there itself. So you pull the graft inside the eye, and now I can control the AC. So you don't have to tap so much over here. You actually want to deepen the anterior chamber as opposed to flatten it. You can see with minimal tapping on the surface over here, the graft is basically already opened up. Okay, and then you basically go underneath and put an air bubble inside the eye. So the advantage of a endothelial in technique, and like this, basically you can see over here, is that it basically involves very minimal tapping on the surface, and especially in situations with phakic eyes, you really worry about disturbing the iris lens, basically diaphragm. Okay, so some of the intraoperative considerations, corneal debris model I do basically on most cases to improve the visibility. I think you must have to do an inferior PI in the children. You cannot expect the kids to basically posture properly, and you must leave a large air bubble. So these are some of the, if it's a phakic eye, I'll always basically use air, but for all the adults, I can tell you I pretty much use SF6 gas in most of my routine cases. I use that double port AC maintainer to stop basically the graft moving inside the eye and maintains the AC depth quite nice. And ideally here, if you're using an endo-in technique, whether you use the endoglide or use any other device to basically put the graft inside the eye, the advantage is that you actually deepen the AC, which is opposite to what you do when you do an endothelium out technique for the AC DMEC, when you want to shallow the anterior chamber to open up the graft. So this is a really distinct advantage in these kind of situations because you avoid basically lens touch and it prevents excessive graft movement inside the anterior chamber. For the stripping, I think it's better or easier to do it with an OVD, like I showed you. It's key that you remove all these tags with basically forceps. Otherwise, your DMEC is basically not gonna stick. I mentioned about the differences techniques of endothelium in or endothelium out, and the advantages of an endothelium in technique in the fact you don't need to basically shallow the anterior chamber, and it requires minimal tapping to unscroll the graft, so there's less vibrations based on the lens capsule itself. So we tried to keep him supine for a day. I mean, he tried, it was difficult to basically keep him flight. I keep the same steroid regime as I basically do for adults. He has G6PD, so he's on top of mycin, he's on hypertonic saline, and we give him a course of oral basically steroids as well. This is what it looked like at basically day one. So we managed to get an art review done for him, contact lens on the surface, nicely stuck basically DMEC graft, 50% air bubble. And then generally with the air bubble, I always see it's about this much at day one, even in adults actually. But in gas, normally slightly more than this itself, but this is acceptable. His IOP was basically 16 at that time. This is what he was like basically at 3 months, where he's got nicely attached graft, pressure is basically good. At 9 months, he's basically now 6'9". He's only on once a day steroid, and he's got basically good self count. There's no evidence of any cataract, which is something that we have to basically monitor on long term. So some of the points of consideration really is recipient preparation, how you're doing the scoring itself. It's a lot more difficult than you think, and it's certainly a lot more difficult than doing adults as well, because the Decimase is really truly stuck onto the back. So as I showed in the video, I did use a reverse Linsky hook basically to do it, but you do find you might have to get shreds. You do try to basically identify the Decimase membrane and try to generally pull it as much as you can, but try to get rid of those underlying Schonwald tags. So if you don't, you're never going to get, I mean, getting a desector stick may be possible, but certainly you're never going to get basically a DMEC strip. If you don't, if there's not a lot of scarring in Decimase and you can really have a good look, there could be an argument for leaving the Decimase membrane behind. I mean, that's something worth considering as well. But a lot of the kids, especially if they're primary Decimase or endothelium or Decimase disease, will have basically scarring there. So you may want to basically remove it as well. You can try to increase the visibility by using trypan blue and endoluminator. That might basically help you in certain situations. Of course, in that graft case, we never remove the Decimase because we don't normally do that basically in the graft when you're doing EK in a graft situation. Insertion techniques for DSEC, of course, there's push techniques, which is 40-60 tackle fold, and pull-in techniques, which is mainly boosting glide, sheets glide, which we described a long time back, and of course, basically the endoglide. Generally, I prefer to use a pull-in technique, so you have much more control inside the eye, especially when the views are very, very poor. The other thing you have to bear in mind is that often the children, especially if they have small eyes, you might get repeated iris prolapse there itself and positive vitreous pressure. And having that tongue on the sheath glide or basically on the endoglide as well can really keep your iris basically back, so it allows you to have a nice operative clean field basically when you're basically pulling in the graft inside the eye. It's very important you suture all the ports before you get the injection, because you will get leakage basically in the eyes itself. When you're inserting the graft itself, if the eye is phakic, you may want to shift your incision so that you basically open the graft. Instead of opening over the middle of the pupil, you open it over the superior parts. You're opening it basically over the iris instead. Using an AC maintainer, like I showed in the video, I think is useful. Giving the pilocarpine is useful. You have to be careful about giving pilocarpine if you're doing a DMEX surgery, because if you get fibrin release from the iris and you're doing an endothelium out technique, then it may actually stick to your graft when you're trying to basically open it up as well. So that might be a bit of an issue. And as I mentioned about the sheet slide, that can basically help. You can use a modified suture pull-through technique, then reduce the amount of instrumentation inside the eye to reduce the risk of basically getting a cataract. If you do a lensectomy, ideally try to put a posterior chamber IOL, otherwise it's going to basically be an aphakic situation, which is going to make it a little bit more tricky when you're going to come and do the graft as well. And sometimes you can do a suture pull-through technique for basically putting the graft inside the eye and hitch the graft to the cornea itself to try to keep it into position. So that will be your first suture, and then you can put another 4 sutures in. So that'll be your anchoring stitch, and you can put another 4 sutures in to keep the graft into position as well. As I mentioned, if you look in the results in the literature, there's not a lot of results, I'd have to say, on pediatric EK surgery, because you can see the technical difficulties in there as well. Some of the reports in the literature, one of the cases here had to be converted to PK because they couldn't basically remove the stromal basically tags, and they had to abandon basically doing a DSEC procedure as well. You have to remember, in certain pediatric cases, the desmoid membrane may be absent, and of course, accidental lens touch can happen in quite a lot of cases. So you need to be careful basically on touching the phakic lens and inducing basically cataract. And there's lots of reasons. Obviously, if the view is basically poor, you've got shallow anterior chamber, and this high posterior vitreous pressure. And I think this is one of the difficulties of doing an endothelial out technique, where you want to shallow the anterior chamber, and this high posterior vitreous pressure can really stop you basically from opening the graft inside the anterior chamber as well. The most common complication reported in literature, apart from graft failure, obviously, is graft detachment in children. Obviously, this is higher than we see in basically adults, even for experienced surgeons. And this is primarily related to the fact that you can have a rough retrocorneal surface, retained desmoid membrane, obviously trying to basically the child may basically rub the eye when he wakes up, which is obviously quite common, or basically can't maintain the posturing, and that's why I'd like to suture the graft into position. I recently started suturing my DMEX as well in children as well, just because on the fact that we cannot rely on the child basically to posture into position as well. You try to reduce this basically with surface massage, but these are all techniques that we basically use in adults. Venting incisions and stuff would obviously work, and I've just highlighted graft suturing, which is one thing I do in a lot of the children, which I very rarely basically do in adults as well. And most of the time, if you can take the graft back, they successfully attach, but you have to remember that you're basically committing that child to another GA, which is, I can tell you the parents are not going to be that happy with that if you have to keep them having too much attachments. Cell loss varies slightly higher than what you'd expect basically in adults, 19 to basically 53%. Endothelial cell loss may be more profound, like we found with Asian eyes, especially if AC is basically shallow, and especially if you have to do the higher vitreous pressure or more intraocular manipulations. The key thing also basically to bear in mind is basically lenticular opacification, and this can occur either from inadvertent lens touch. Obviously, it can be related to the primary disease. So sometimes repeaters, of course, we know that you can get endothelial problems, and some of the other diseases giving you anti-segment dysgenesis. It's important to tell the parents, obviously, there's some cataract basically there even beforehand. So they don't blame the steroids, or they don't blame your inadvertent touch from surgery, or basically using the gas. Of course, you can get hypoxic damage from prolonged air tamponade and gas. So obviously, we never use gas in these children. We do use air, and I do try to reduce the air level as fast as I can, but normally you'll see it will go after 2-3 days itself. It's a balance basically of trying to not to have prolonged air injection and not get basically graft attachment. And I think that's the balance that you have to basically discuss with the parents basically beforehand, because otherwise if the graft attaches, of course, it's going to require recurrent surgical intervention. And that's why I have a low threshold for suturing the graft. If you suture the graft, you must do it on day one at the time of the surgery. It's a lot more difficult to go back in and suture a graft when the view is very, very poor, because then the cornea will be much more swollen the next day if the graft is basically dislocated. Remember, in children, you do get more inflammation, so I do like to give them some syrup afterwards and try to cut down the steroids a little bit faster than we basically do in adults once you've got control of basically the inflammation. But cataract incidence can be as high as basically 40% of pediatric cases as well, and this may require secondary basically removal of lens at an earlier stage with an intraocular lens basically implant as well. One of the issues with basically monitoring the kids, of course, is immunological rejection, which we know in adults we can pick this up early, and typically in DSEC and also in DMEC, if you do manage to see rejection, often it's very, very subtle compared to what we see basically with penetrating keratoplasty. Sometimes it's just a few KPs, then you get a little bit of inflammation. Now, this is easy to pick up in adults, but in children, it can be very, very difficult to basically pick this up because it can basically be so subtle as well. So it has been diagnosed in a pediatric population, of course, but obviously the child's inability to report a sudden loss in the vision itself or the inability to cooperate on a slit lamp will also make this a lot more basically difficult to diagnose. Other things that have been documented have basically been persistent stromal haze, and this is one of the issues. If you leave the disease too long in the children, then the stroma just does not basically clear, or you can see progressive anterior fibrosis from intense basically inflammation. And you have to bear in mind that if you manage to get through all of that, you have to basically then deal with a coexistent amblyopia, which may basically limit the final vision results. But the key advantage is you would expect the quality of vision, if you can do these EK surgeries in the children, to be far better than if the child has undergone a penetrating keratoplasty. So CHED is the most common indication for basically DSEC, and compared to basically PK, there have been a few studies reported in the literature. Generally, the CHED cases, they have obviously a faster visual recovery after basically EK surgery compared to penetrating keratoplasty. And the cornea can basically clear much faster and will maybe continue clearing for a year. And we've previously seen this and documented this in basically in adult cases of stromal edema. It may be particularly faster in a younger age group, maybe because the edema is not so worse and you haven't got those changes in the gags compared to what you see basically in the older age group as well. It's difficult to really assess if obviously sometimes the visual outcome basically in children after DSEC. So when I show you some of the data, you have to basically bear that in mind. There can be unreliability of the preoperative refraction with advanced corneal disease, and there may be a tendency bias as well for children to report better results. And as I mentioned, Yang in one of the publications suggested that infants may benefit more than older children. So basically, if you're doing an EK surgery in a younger child, basically the faster clearing of the corneal edema may aid basically the ability to basically start amblyopia therapy slightly earlier as well. Same as in adults associated with a hyperopic shift, you do get the average astigmatism induced by the wounds is almost about 3 diopters, so it's much higher than basically what you see in adults, and this is because of the lack of rigidity of the sclera and also the cornea in the children as well. Really, you can get a basically myopic shift in the eye itself. And you have to bear in mind that obviously you're going to get natural growth of the eye over the first couple of years as well. As the eyeball basically is growing, you're going to basically get a shift in the refraction as well. There are many causes about why the visual acuity may not basically pick up, and of course this needs to be discussed with the parents. Inability to determine the amount of stromal edema at preoperative assessment. I mean, I like using UPM and OCT to basically help me in that, but this maybe have to be done under sedation, or in OCT we have an OCT and OT, so I can scan the kids when they're asleep under GA to basically have a good look at the stroma as well. There can be residual corneal haze, and of course basically amblyopia therapy needs to be done as well. But the best benefits are basically done when basically it's a localized posterior stromal opacity, like I showed you basically in the DMEC case, with obviously minimal anterior volume. But there's significant advantages, of course, as we know in DSEC. One of the disadvantages of DSEC is that it doesn't give you basically that clarity of the stroma that sometimes we basically see, that we sometimes see as chronic basically in children as well. If you look at the results in the literature, this is a table that we basically made. We look at primary causes, basically CHED, a few here of type 2 anomalies. You can see the numbers of eyes is not huge. This is the largest series basically over here from Yang with basically 30 eyes, and the age of the surgery between 6 months and 13 years itself. The follow-up is pretty decent in this surgery, but almost up to 5 years as well. You'll see the visual acuity results do vary in the literature as well. So you have to bear that in mind. And generally speaking, most people would feel that results are at least as, if not superior, to what is basically achievable with penetrating keratoplasty. And the idea is you kind of limit the number of complications that you get compared to PK as well. Now, pediatric DMEC is a whole another sort of kettle of fish, so to speak. There are very few reports in the literature. In fact, this is one of the first reports back in 2014 of a 12-year-old child who had Kearns-Sayre syndrome and basically underwent DMEC and actually got pretty good visual acuity result basically at 6 months. This is the second report published, I think it's in 2017. Okay, of a DMEC for a similar child with PPCD. But this is a 4-month-old fake it kid as well. This didn't go so well. The graft was basically found in the anterior chamber at day 5 post-op, and even despite the best attempts of the surgeon to unscroll the graft and rebubble, the child had to undergo a DSEC. So these are not easy surgery procedures performed in children, and this has to be discussed with the parents about whether it warrants you basically trying to push to do a DMEC in a child when you might be better off basically doing a DSEC in this situation. So this requires a lot of discussion with the parents as well. So the last thing I'm going to talk about is a sort of a newer thing. Regenerative therapy, you'll see, was from my first chart. And Peters anomaly is the sort of archetypal disease where we look at as a regenerative therapy approach. So Peters anomaly is divided up basically into 3 types. Of sort of milder form is in type 1, secondary form obviously involving lens type 2, and Peters plus involves several other features in the body as well. And it's obviously related to mutations in all the anterior segment dysgenesis genes, so PAX6, PEDX2, FOXC1, and CYP1B are all basically implicated. About 70% of the cases are bilateral diseases as well. The management of basically Peters anomaly is basically for mild opacities, large peripheral iridectomy, or basically mydriasis. And if you look at this large basically series from the literature, what you'll see is if you look at the preoperative visual acuity compared to the postoperative visual acuity, of course, the kids that have basically the bilateral disease seem to do better than the unilateral disease as well. So of course, you have the amblyopia driving basically the unilateral disease itself. So often they basically don't do so well in that situation. If you look at other basically series where they've looked at basically surgical intervention, of course, eyes that underwent surgical intervention such as penetrating keratoplasty or basically large eyes, it's better if you have a prognosis of basically type 1. You can see on the survival curve over here compared to basically type 2 disease, but you have to bear in mind that of course, just because the graft survives, it doesn't mean the child can actually see quite well. If you look at another paper over here on the left-hand side of 166 eyes, out of which 44 eyes underwent surgical intervention, you will see that most of the eyes themselves, there are only 2 or 3 eyes that get basically mild visual acuity, which is between 2100 and basically 2050. And most of the eyes are actually in the region of down over here itself with respect to improvement in visual acuity. And of course, this seems to be this is worse in basically unilateral disease compared to basically bilateral disease. So generally speaking, what the results are telling us is that the children don't do so well with respect to their outcomes. If you do a graft, they slightly do better basically with type 1 disease compared to type 2 disease. So a few years back, we were doing some work trying to understand endothelial cell migration basically behavior. And what we found is that there is an age-dependent effect on basically endothelial migration. The second thing that basically we found is that the human endothelial cells, when you basically do the experiment on cadaver eyes, they prefer to have an intact desmoid membrane when basically we're doing the basically migration. And you can see here that by adding in basically ROCK inhibitor, it allows you to basically increase the endothelial migration speed of the 70-year-old adult from 10% all the way basically up to 80%. So there are 3 points that we learned. Human endothelial cells prefer a basement membrane. Age has an effect. So below the age of 40, the migration is far better, and ROCK inhibitor can negate the effect of basically aging. So basically what we did was we basically did an experiment in some animals where what we wanted to do was compare the endothelial migration speed in what we basically did a scrape model where we remove the endothelium and left the desmoid membrane behind, and in another model here where we peeled away the desmoid membrane and the endothelium. And what you can basically see on the bar chart is that if you peel away the endothelium, so you remove the desmoid membrane itself, the corneal edema goes up to about 1500 and it starts to recover. This is a rabbit model, so this is obviously typically can regenerate. But actually, if you leave the desmoid membrane behind, the recovery is basically much faster. Okay, so the cells like to basically migrate across the recovery. So this gave us an idea that a possible therapy for endothelial disease could basically be the removal of endothelial cells. And because we know this works much better in younger situations, we could probably have an age effect where you can get some sort of endothelial migration to close up basically the defect. And of course, we know in DSO now, basically from surgery in adults, that we know this is also basically even possible in adults as well, although it requires some sort of basically modification. This gave us an idea of a new therapy that to try in basically children. So at the same time, I saw this girl, this is about basically 4 years ago now, and she basically presented at 3 months to a colleague of mine with a central corneal opacity. She had no birth history of note, The left eye was basically normal. On the right eye, you can see over here from the picture, she had a 5mm corneal opacity. On UBM, you can see these iridocorneal adhesions to the central part of the eye. The lens basically looked okay, optic nerve was okay. A-scan was basically showed to have a slightly smaller eye, 17.6, 18.4. Intraocular pressure was basically okay. And the visual acuity of forced choice preferential looking was 2960 on the right eye and 2130 on the left eye. She was given pediatric drops, then occlusion therapy, which is what most people will do to start with, and basically to hold to come back. So she was lost to follow-up. So she came back when she was 18 months old, and this is when I saw her. She had no change in vision. She'd been seeing several ophthalmologists to get different opinions. People told advised her to do a PK and adhesiolitis, and EK and adhesiolitis, and someone even offered her a Boston K-Pro. Now, one of the things about type 1 Peters, as basically that child basically has, is that often the endothelial cells are attenuated on a very immature, basically decimated membrane. And this is what leads to localized loss of endothelial pump function. But typically, the peripheral cells are basically normal. And there are reports in the literature of spontaneous clearing opacities, especially from this publication from Japan. But you can see from here at 2 months compared to 4 years, it took almost 4 years basically for the cornea to clear. And typically this happens when the iris is basically intact or is in a round, basically, or the pupil is basically round. So there's no abnormalities of the iris onto the surface. So the cornea cells can migrate over here and clear this pupil, but this takes a long time, or basically almost 4 years. So what we thought is it possible that we could stimulate this process to occur at a much earlier time? And this gave us the idea of a surgery that we called selective endothelial removal, and basically we combined this basically with adhesiolisis in this situation. So this is just an example of another child, a patient of mine, basically at 1 month old, and basically typically you can see here at 3 months, basically when the child came back, the opacity is basically cleared. And he also has that 1 Peters, but all I did for him was to dilate his pupil and start basically mydriatic basically therapy. By doing mydriasis and removing the iris adhesions, if they do come off naturally, you can clear that central cornea. So this can happen if you basically start mydriasis therapy like that, basically like that patient, and I showed you earlier that had mydriasis therapy but didn't clear in that situation. But it's definitely worth trying because it may clear. I thought this was a good example basically to show from this. Okay, so this is a surgery. So basically put an AC maintainer in. This is a silicone tip cannula, and what we're doing is we're gently removing the diseased endothelium from basically the central area. So typically under the area of where the opacity is. Okay, so we're going to go in through a small paracentesis. You keep the AC as deep as basically possible. So I'm releasing the adhesions, and underneath where the opacity is, basically around that area, I'm injecting some trypan blue to basically have a look, to basically see if the endothelium is removed. You can see over here the endothelium has basically been removed, basically around that area. You can see the staining, and the rest of the cornea is not basically stained. I'm just putting in an air bubble here to show that there's basically no tears in decimated membrane. The decimated membrane is intact, and then just filling up the AC and suturing up the incision. So it's a pretty fast surgical procedure basically to do compared to doing a graft in the situation. This just shows you basically the surgery again. So an AC maintainer to keep the AC deep, the silicone tip cannula to basically remove the endothelial cells in the diseased area. You can see the vision blue staining around the area of the scar, so the endothelium is basically removed from there itself. And I just put an air bubble in to show that the decimated membrane is intact. So you can't see the decimated membrane is basically stripped around this area as well. So 6 weeks later, we went back, went to remove the scar, and I just wanted to have a look and see what was basically happening. We see where the endothelial cells had migrated. I injected some BSS with trypan blue, and you can see now it's quite interesting. What's happened is that the lens is basically stained, but the cornea now is completely cleared up. So there's no staining on the back of that scar from there itself, which means the endothelial cells have basically migrated across that area and have sealed off on the back of the scar. So this is what the child looked like pre-op, and this is basically looking at 6 weeks. And you can see actually there's some change basically already in the scarring over that time, but obviously you have to bear in mind the scar has been there basically for 18 months. This is what the child looked at 1 week. This is what the child looked at 3 months. This is what the child looked at 6 months. This is what the child basically looked at 1 year. You can see the improvement in the visual acuity, and also basically the central corneal thickness has come down. It's typically got a little nebula at the back of the cornea over here as well, which is something that you see normally in Peters and normally, but you can see a significant improvement in basically the corneal opacification as well. This is the refraction at the child, basically when we saw him basically at 1 year, and this is basically how it's settled down now. He's ended up with 20/30 vision basically in this eye at 30 months now. I think he's now 4 years basically post-op. I was on no topical steroids at all, but is undergoing basically amblyopia therapy. And you can see that very faint scar still there itself, because you get those chronic gag changes in the gags, but I think that'll improve basically in time. And ideally, it would have been nicer to intervene at a slightly earlier rate to basically stop this from happening. This is a pretty reasonable result considering where the child basically started off. So these are some of the other cases we've done. So this is basically pre-op. This is now almost at 30. I think it's almost 3 years now, basically follow-up. We almost got 4-year follow-up basically on the first kid. These are some other children. This is case 2 and case 3. So you can see exactly the same thing on UBM with 930 micron basically corneas and quite central dense basically opacities. This time now, what we do is that generally I go in slightly earlier, normally within a year. And you can see over here at 3 months post-op, case 2 is nicely scaled up down to 460. In case 3 over here is 540 microns. And this is basically this is now at 12 months over here. There's now 440 microns of visual acuity is basically improving. Intraocular is clear, and you can see nicely the pupil margins over here, basically on both sides, and an improvement in the central corneal thickness as well. This is just this is the whole series we've done, about 5 cases now. This is just the first 4 cases. This is when they see them at pre-op, and this is what you see basically at last follow-up over here. So they're on no topical steroids. You can see the massive improvement in the corneal clarity with this the minimally invasive therapeutic approach that we call SER, selective endothelial removal for Peters anomaly. So in conclusion, in adult, corneal transplantation has changed dramatically over the 20 years for endothelial disease. Surgery for pediatric endothelial disease is more complicated than in adults due to several anatomical and physiological issues. However, children have the most to gain by these new techniques due to faster visual recovery, lower risk of rejection, fewer drops, less postoperative complication, and faster amblyopia treatment. Surgical modification is needed, but it can give you safe and efficacious surgery in this age group. And obviously, we need more cases in literature for more surgeons to see how we basically see with the outcomes. But these are difficult cases to do, I have to say. Our ex vivo model and migration work gave us the idea to try a new technique of minimally invasive therapy, regenerative therapy technique for type 1 Peters that we called selective endothelial removal. Our first in child case, so this is the first child now. She's now basically, this is when I saw her 18 months. And now she's basically up to, we have almost 4.5-year follow-up. She's 5 years basically old now. We've done 5 cases in total, over 40 cases I know have been done in India, and about 4 to 5 cases in the United States as well. Thank you for your attention.
Thank you for a wonderful and a comprehensive talk on the topic. Very interesting work. So we have some questions on the chat as well as from the panelists. Can we start with the panelists, please? Any of you have any questions? Gavit, Lakshay, Akanksha, Tulika.
Hi, sir. Good evening. Thank you for the nice talk. So I have 2 questions in particular. One is, do you pay any particular attention while selecting grafts for the children? I mean, other than the usual criteria we follow for adults, what are the extra things you look forward to?
You can't. So if you're going to do, I mean, if you're doing it, so it depends on what kind of graft you're doing, right? So I mean, if you're doing a PK, it's different. I mean, if it's PK, then of course I'll try to get a tissue with a high endothelial cell count. Okay, but for EK surgery, you're already limited in the fact that you've got it for the same. If I'm going to do a DMEC, I won't take tissue from somebody less than the age of 45. Non-diabetics, we have a whole criteria, which is our standard basically that we'll take for DMEC tissue. Likewise, similarly for DSEC. So all we're trying to do is try to take tissue with as good as endothelial cell count as possible. Okay, but these are older tissues than compared to say a penetrating keratoplasty in a child.
Thank you. And about the first case, you had taken stay sutures. What special precautions you take, because they are through and through sutures? So do you take special precautions to prevent infection, and when do you remove them?
So it has to be a long stitch when you pass through. Okay, you have to make sure the epithelium is all removed basically around that area. Okay, if you do this, if the stitching is too small, what you'll do is you'll get puckering of the DSEC graft in that area itself. So it must be a long suture 1. These are just ordinary 10-0 nylon sutures, like we like Manny sutures because it's very sharp and quite fine. The sutures need to be rotated. Okay, contact lens on the child basically afterwards from the surgery. Normally, I'll remove the stitches at 6 to 8 weeks post-op, because then the graft is stuck. If you're not sure when to remove it, if the child can have an OCT scan, then you can look around to make sure that the graft is all stuck around in that area. But typically, if you can see the areas that the graft is stuck around, normally you can remove. Normally, I'll remove them on the slit lamp actually for most of the kids itself, and they're quite easy to basically remove.
Thank you.
Can we start with the questions? Harika, can we start with the questions from the panel?
Yes, sir. So I'll be taking a few questions on different portals. The first question is, what are the practical tips you give to the beginners of pediatric DSEC?
So the practical tips would be do as many adults as possible. Okay, so I still think that I still think it's a realm of really for corneal people. I mean, at our place, the transplants, the pediatric transplants are done by the corneal surgeons, not the pediatric surgeons. But everything is basically managed as basically as a group, right? You need a team approach over here as well, because you can have to think about amblyopia therapy. Probably have to work well, have a glaucoma surgeon on board as well. So I think you need to be pretty competent DSEC adult surgeon to understand all the things from them before you're going to start basically doing kids. When you start with, ideally, I mean, you're going to be doing cases like that don't have good views, like I basically showed with that kid with the previous graft. I mean, these are the kind of cases actually to do. Actually, these are kind of quite good cases basically to start off with, because even though the views are terrible, the outcomes actually are very, very, very rewarding itself. But a lot of the children are aphakic. They've had previous cataract surgery. That's why they basically can't see. So understanding how you basically do all the air management stuff is all the tips that you understand when you're doing these cases in the adult. The only thing is the difference is in the child, you haven't got the room forever that you have in the adult, because as an adult, if you need to rebubble, you can take them back, stick them on a slit lamp, take them to OT, do an LA. In child, you can't do that. Okay, so those are the things that you need to really consider. But I would never get somebody, or would never advise anybody to be just doing EK, I think, in children, because I think that they're too difficult. They're difficult, and I think you need to be a reasonably competent adult EK surgeon before you transition over into children.
Yes, sir. The next question is, what are the most common reasons for graft dislocation in children and how to manage them?
So the most common, I mean, basically the children don't posture. It's very difficult to get the child to basically posture. Eye rubbing, obviously, for the children is basically difficult as well. So you're faced with those two things, and they're the two things that in adults that you rely on basically on the graft itself. The third thing is that making sure you've got good tamponade of gas, or you're using air anyway inside the eye itself. So those are the three things that are important to basically try to maintain. The tamponading, or the good tamponade in the anterior chamber you can maintain, but making sure you suture up everything so it's absolutely airtight before you leave the OT. The second thing, as I've said, I do like basically suturing the grafts. I think that's probably avoids the issue with basically of the posturing itself. And the third thing is making sure you keep the shield on at least 24 hours. Don't try not to get the kid to rub the eye, so they have a shield on the eye itself for 24 hours before you basically remove it, and then basically have a look at the eye itself. Those are the sort of things that I basically do to try to keep the dislocation rate down. But you do need to tell the parents that there is a chance that it's going to dislocate, and so that they're aware of the situation, because obviously if you did a penetrating keratoplasty, you avoid it, but of course you're trying to do something that gives them a slightly better outcome. So that's the balance that you need to have the discussion with the parents with.
Okay, sir. The next question is, the hyperopic and the myopic shift you have mentioned post DSEC, would it be temporary or sort of permanent, and how commonly do we see this?
Well, so the issue is the size of the graft, right? So basically, you've got to bear in mind that you're putting with grafts that have been cut with microkeratome, they're going to be a minuscule to cut. Typically, you get a disparity between the peripheral edge and basically the central edge. So the larger the disparity, the greater the basically the hyperopic shift. Okay, so one of the ways you can try to sort of negate that is by putting in thin grafts. So generally speaking, for kids, I try to put in slightly thinner grafts, but then you have to be okay to handle a thin graft inside the eye. But the advantage of being able to do that, if you can handle a thin graft, is that you don't get so much of basically a shift in the refraction. That's the big advantage basically to do that itself. The downside is the manipulation inside the eye, opening up the graft, if you're okay with basically being able to do that. But if you do a suture technique, or pull through on a suture on a sheet glide, which is, I think a pretty reasonable technique, where you're using a boosting glide and you're pulling it in, it actually makes the surgery a little bit easier. You can hold the suture into the graft, but at least you've got the graft in position. And even if the graft is thin, you'll at least basically get it into position itself. So it'll basically be in the right position to open.
Okay, sir. So what are the early signs of graft failure, and how early can we do a regraft, and how many times a graft can be repeated in children?
Yeah, so I mean, the problem with it is that rejection with EK is not as obvious as basically with PK, with redness, red eyes, things like that. I'm not saying not in a previous, obviously if in a previous penetrating keratoplasty, of course, then you will basically see that. But in a virgin eye with not a previous graft, you won't get it until it's quite formal. So this is the problem, basically. The children may not present, or they may not tell their parents they can't see basically in that eye as well. So if you do see it, you do need to be quite aggressive with the topical steroids and the oral steroid basically therapy in that situation. I would give it at least a go for a couple of weeks basically on steroid therapy before even considering basically doing a regraft, because you want to basically try to give the best sort of survival of that graft itself. How many times can you repeat the graft? The reason why we did an EK in that situation under that PK, even though the surgery was difficult, is because previously in adults, we've shown that it's 5 years survival. If you have a PK-PK versus a PK-EK, your PK-EK grafts almost have 90% survival at 5 years compared to your PK-PK graft, which is down to almost about 50%. So what that means is that if it's possible, but that's in an adult cohort. So it means that if it's possible to do an EK under a PK, they do basically much better. So I'd much rather happily do that, because it is still small incision surgery compared to having to do multiple PKs. Because we all know that basically doing multiple PK surgery, the graft's going to fail. How many times can you do it? Well, I mean, you want to do it as least as possible, right? So, but you have to bear in mind, obviously, with people living longer, it's more than likely that that child was going to have multiple grafts basically as the child's getting over. But you may find, if that child now, he's had a PK done at 10 months old, now he's 10 years old, okay, the graft basically went on for that, or I think I did the graft for him when he was like 10. So now this new EK, hopefully this will last him a bit longer and stuff. And then later on, maybe he'll get cell injection or maybe get DMEC and stuff. So he will go through different iterations of graft, hopefully reducing his risk of basically getting rejection as he's had different surgery. But as long as you can try to keep the whole keyhole concept, I mean, that other kid with the who's got the DMEC, of course, when that DMEC fails, when he's older and stuff, and he's 9, 10 years old now, but when he's in his 20s, if that DMEC fails, we can just take it out and do another DMEC for him. So then we'd expect the second DMEC also to last quite a long time.
Okay, sir. The next question is, what are the most common indications for secondary pediatric keratoplasty, and how successful is the procedure in these patients?
Secondary. So the most common, I would say, I mean, I showed on that list basically of the most of the common. I mean, CHED is quite high. CHED, PPCD, previous PK, I think is quite high. That's the third most common cause of basically regrafting. Is quite high as well. Those are the most common diseases that we basically see. We need to do basically grafting.
Okay, so the next question is, how far these surgeries are successful in congenital anterior staphylomas cases, and what options do we have for these children?
Yeah, so they can be quite basically complicated basically to do. I mean, I think that so it depends on, when you get congenital staphyloma, I mean, obviously there can be a variation, right? So you can get a spread of basically conditions as well. The ones that are very, very severe, I think there's no choice. You're going to have to do basically penetrating keratoplasty. Obviously in that situation, you have to bear in mind that that's why, still 50% of the cases are getting penetrating keratoplasty. So you can see by the numbers, we pick and choose those cases that we feel that we can do EK on, or lamellar surgery on itself. But I think that in most of those cases, you're going to have to probably do PK on. Okay, unless it's basically mild, where you think it's possible that you could get away with an EK surgery as well. We describe a technique in adults, which we haven't done in children, where you can have significant stromal scarring, where we combine, where first of all, we will do, and they have endothelial disease. First of all, we will do an EK surgery, typically a DSEC, and then we'll leave it maybe 6 months, 1 year down the line, and then we'll go back and do a DOLF on top of basically the DSEC itself. And we do that as a dual basically approach procedure, but we've never done it in a child yet.
Okay, sir. The next question is, what precautions are to be kept in mind in children with ophthalmos undergoing keratoplasty?
Yeah, so everything is very soft. So there's lack of rigidity. So rigidity is a huge issue. Okay. Often obviously the child may be under obviously glaucoma team, so you don't know if there's a tube inside the eye. So you have all the issues basically of managing basically the tube as well, in basically a situation of where the eyes basically got no basically rigidity. So all the issues that I show with basically stripping away the Descemet's membrane, getting the graft, you're going to have a huge anterior chamber. All those issues are basically going to come to play in this basically situation. But I still think that it's possible to do, it's maybe better to do an EK procedure than having to do a PK procedure first time.
Okay, sir. The next question is, what is the role of irrigating cannula in these cases?
Irrigating cannula. What do you mean in normal EK cases?
Yes.
So I don't normally use an irrigating cannula. I use an AC maintainer. It's an AC maintainer. So it's an AC maintainer and it's got 2 ports. So the idea is we use the same one in adults. So the idea, if you have a jet, we only use it for DMEC. We don't use it for DSEC. For DMEC, when you pull in the graft inside the eye, if you have a fluid jet coming from one location, because the DMEC graft is so thin, it'll often move around the anterior chamber. So the idea of having 2 ports there, the fluid is then divided, and then you can maintain the AC depth. So you have you can deepen the AC, but the graft doesn't move. So it reduces the movement of the graft inside the eye. That's why there's 2 ports.
Thank you so much, sir, for patiently taking all the questions.
Okay.
If any other panelists have some questions, you can please ask.
Lakshay, Akanksha, Tulika, do you have any questions?
So I had a question regarding, you told us about the use of topical steroids in these cases. Do you give oral steroids routinely to your pediatric keratoplasty patients? And what is the protocol that you follow for them?
Yeah, so we give syrup basically. So we'll give steroid syrup, and then we normally basically weigh the child. It's normally done basically on the child's weight. So either between 0.5 or 1 milligram per kilogram, we'll basically give them as syrup. Most of the kids won't tolerate. I don't think they'll tolerate orals, but definitely they'll all get. Even in the routine cases, where that the first case was obviously a previous PK, but even in the routine cases where they don't have a previous graft, I'll still give oral steroids as well, because you can't be so reliant on the fact that the parents are going to get all the topical steroids in as well. So we just give them a short course of basically of syrup as well.
And how long do you continue the oral steroids, sir?
So we normally cut the dose down basically by 0.5 milligrams every 5 days.
Okay.
So it comes to about 4 weeks basically.
Okay. Thank you.
So if there are no further questions, let me thank Jodh for his wonderful talk and for taking time out for iFocus. It's quite late in Singapore. Sorry for so long. Thank you so much, Jodh.
Okay, thank you, Santosh. Thanks for the invitation. Thank you, guys. Thank you.